Elizabeth Wedberg is an RN, MSN, wow, got a master's in it too, an ACNS-BC, I'm going to ask you what that one is, and then CNRN. As I said, Elizabeth has joined us from Austin, Texas, where she lives there with her husband currently. She is board certified adult health clinical nurse specialist who has been with the Seton Healthcare family since 2007 at the Seton Brain and Spine Institute Neurology. After she received her bachelor's in psychology from Austin College, she completed a Master of Science Nursing at the University of Texas. So do I say go Horns? So Elizabeth, thank you so much for joining us. We got people coming in here from Georgia. We got people from New York. So I'm going to turn it over to you for your presentation, and I'll look forward to it. I'll be turning off my camera and mic and turning it over to you. Thank you, Elizabeth.
Thank you, Chuck. Hi, everyone. My name is Liz Wedberg Savam. As Chuck so kindly said in my introduction, I'm from Texas. I will try not to get any type of twang in there for you. It's only when I'm really tired. But I am from Austin. We're having great weather here, so I do hope that you're having good weather where you are. If not, come on down. As Chuck said, we're going to do a quick talk about VNS, and LivaNova is the company. The vagal nerve stimulator, or VNS device, is the device we'll be talking about tonight. The presentation will take about a half hour, and then after that, we're going to save enough time for Q&A. I am informal in this in the sense that I want you guys to really understand what we're doing. And so if you have any questions throughout the presentation, if it were live, we would take it then, but since we can't, if you could, just please put it in the chat box so that we can come back to it at the end of the presentation. I am going to talk about the FDA indications on this. If there's anything outside of that you guys would like answers to, I will answer that to the best of my professional opinion. If there's something we can't answer, I don't know the answer to, we can have you contact LivaNova. Again, outside of this, we can contact you and see if we can get that answered for you. I wanted to say thank you to the Anita Kaufman Foundation for having me here tonight. This is a LivaNova talk, so if you have any questions or you have any desire to know more about this after the talk, please feel free to go to their website, which will be referenced at the end of this. And if you guys would, we're going to go ahead and I'm going to share my screen and we are going to go ahead and get started. All right, I think everybody can see it. If not, please, Chuck, let me know. But we're going to it's an introduction to VNS therapy or vagal nerve stimulation. If you've heard a little bit of this before, just bear with us. We'll get into more for you at the Q&A afterwards. But again, we're going to get through this as quickly and painlessly as possible so that I can answer any questions for you. So tonight why are we here? What are we talking about? If you're here for Purple Day, you understand that epilepsy is something that afflicts all kinds of people. And so tonight what we're going to talk about is the drug-resistant epilepsy, seizure freedom with medications or chances that you cannot be with medications, VNS therapy, which is a treatment option for seizures. It's specifically a surgical intervention. And at the end of today, I hope that I answer your questions and that we can actually give you some resources more about the vagus nerve stimulator and that you can go back to your providers and have honest conversations about it. So if you didn't know, this is from the Epilepsy Foundation. They have this on here, and if you look at the bottom, it's from 2015. It's also referenced in multiple journal articles. About 3.4 million Americans live with active epilepsy. However, over the last 30 years, despite many new medications, seizure freedom rates for newly diagnosed epilepsy have not improved. So what this means is if you're someone who's had their first seizure in the last 2 or 3 years, despite multiple medications that have come to the market, even in the 15 years that I've been doing this, our seizure freedom rates and good control of that has not improved, which is what we would expect. We have new mechanisms of action. We have more sophisticated mechanisms of action with medications. However, we have not seen that exponential increase in seizure freedom or seizure control that we would expect. So there's this population over here. If you look on the purple area, about 35% is drug resistant. That is a very specific definition when we talk about drug-resistant epilepsy. Where I work, which is Seton Brain and Spine Institute, now we're transitioning to Ascension Medical Group, but it's essentially the same people. We are a level 4 medical surgical epilepsy center. So in the National Association of Epilepsy Centers, what a level 4 means is You do medical management for epilepsy, but you also do surgical intervention. And when you talk about outside interventions other than medications, that's when we're talking about drug-resistant populations. So this is what we do on a daily basis. You come to people like me and my colleagues when medications have not necessarily helped you in the ways that we would have expected. So when we talk about drug resistant, this is a definition through the American Epilepsy Society and the International League Against Epilepsy. And what that means is 2 anti-epileptic medications or 2 anti-seizure medications that have failed to control seizures. And what we're talking about then is just adding another medication is not necessarily going to give you that increase in control. So when you talk about medications, this is very important if you're a patient or if you're a family member of a patient. The medications have to be appropriately chosen. What that means is if you start a medication and you only take it for a day or 2 and then you say, well, it didn't work, I just, we're going to move on, it didn't do anything. That's not a good medication trial and failure. What we talk about is choosing the right medication for you, meaning is it focal epilepsy or generalized epilepsy? If you have any syndromes like Lennox-Gastaut or Dravet's or anything like that, when from a pediatric standpoint, there's very specific medications that you look at. We have to make sure it's an appropriately chosen medication, given enough time on that medication, and given it the right dose. So what that means for us is just at the starting dose, if it's tolerable and we haven't tried above that, that doesn't necessarily mean it's a failure. What we want to make sure of, and what you should as a patient and as a family member or a friend, is that make sure before we talk about anything, especially brain surgery, which is not here, but in general, make sure that when you look at the medications, you've actually done the medication trials that are appropriate when you see that epilepsy specialist. But what we're talking about tonight is drug-resistant epilepsy, and outside of medications, what can we utilize? One of the things we can utilize is epilepsy surgery. There are other types of surgery. There are intracranial surgeries or brain surgeries. That includes resections, that includes DBS or deep brain stimulators, that also includes responsive neurostimulator devices or the RNS device from NeuroPace. Different talks. You're here for VNS and you're here for LivaNova talk. LivaNova and the vagal nerve stimulator is the only device that is extracranial. What that means is that it's not in the brain. This is not brain surgery. I think I did that, and I sincerely apologize. I don't even know how I drew on that. I apologize.
Liz, I apologize. One of our guests hit annotate on the screen.
Oh, whoever that was, thank you. If I get red, it was because of you.
Yeah.
Chuck, I really thought I colored. No, it's okay.
It should be turned off.
That's so okay. Sorry. I hope it was your child and they were coloring because they were so entertained. So what we're talking about is not the intracranial devices or brain surgery. What we're talking about is the only device on the market right now that is extracranial, meaning it's not in the brain. And this device is VNS therapy or vagal nerve stimulation. And it is a device specifically designed for people with drug-resistant epilepsy and is a safe and proven long-term solution. What is not included in this slide deck is that LivaNova as a company started debuting this over 25 years ago. They have 25 years plus at this point of research and device programming, management, and R&D that have gone into this, that we have had multiple waves and multiple different models that have come through. So when we talk about, is this something safe? It's been on the market for close to 30 years over in Europe and over 25 years here in the United States alone. The FDA approval is add-on therapy for people as young as 4 for partial onset seizures. If you're familiar with the newer vernacular, that is focal aware, focal unaware, or focal onset seizures. But FDA approval, that literature says partial onset seizures, so that's what we go by in these slides. Basically, what we're talking about is epilepsy that starts in one area of your brain. It can generalize, so if you have generalized seizures, as long as it's a focal onset or a partial onset seizure that then can generalize, there's FDA indication for VNS. It is used by more than 125,000 people around the world, including 33,000 children. That FDA approval for 4-year-olds was updated within the last 5 years. Forgive my memory. It used to be 12. So now that we've gone down to 4, I expect that number for children to go way up in the next 5 to 10, even and longer than that. I think it will much more match the adult population or potentially even exceed that as an option for children outside of medication. The primary goal of VNS therapy is to prevent seizures before they start and to stop them if they do. So what we want to talk about, let me go back real quick, because the bottom here is everything we do in epilepsy is to prevent seizures. I don't want you to think that I'm sitting here selling you something, because I'm not a salesman. That's everyone else's job. What I want you to know is when we talk about prevention of seizures, that's the first and primary goalpost for any treatment. So the reason that I like VNS therapy, the reason that I'm here talking to you guys about it is I know it's effective, safe, and proven solution for seizures. I would love to tell you it would prevent all seizures. I can't tell you that honestly, and I wouldn't do that. If you have a provider that says this thing is going to cure everything, that's when you maybe need to get a second opinion. I'm not saying they're wrong. We would have to know your specific case. However, the goal is always seizure freedom. If we can't get there, secondary goals include decreased severity of your seizures, decreased frequency of your seizures, decrease the risk for injury with these seizures. If I can take you from having generalized tonic-clonic seizures or even nocturnal convulsions where you have seizures out of your sleep that can cause injury, if I can transition that into a focal seizure or even a staring spell, or instead of 60 seconds, you go down to 10 seconds, your recovery time is going to be better, your risk for injury is going to be better, and overall quality of life will improve simply because your brain is not being exposed to that prolonged seizure. And I think that the slide deck talks about this. If not, we can go into it in the Q&A session. The newest component, the auto stimulation, which we will go into in the next couple of slides, that is one of the biggest things if you're looking at how can I help myself or my family member decrease the risk of hurting themselves, decrease the risk of death related to seizures. VNS with the auto stimulation feature decreases the risk for SUDEP by greater than 50%. There is nothing else on the market that I can tell you, medications, even surgical interventions, that has the proven research to say it will decrease the risk for death related to seizures by greater than 50%. So if you have more questions about that, please feel free to put that in the chat. We can get into that more later when we talk about the different stimulation modes. But also there is research out there that shows that, and LivaNova will also reference that on their website as well. So why would VNS be right for you? I would gladly I want you to have these conversations with your provider. I want you to have them with me if you're my patient. So why would you talk to us about it? If you're still having seizures despite trying at least 2 prescribed medications, the time it takes you to recover is interfering with your quality of life, like we just talked about. You have side effects to your current treatment plan, and they're having a negative impact. I had a patient, sweet, very, very sweet man, came to us in his 30s, and he was on a medication that was causing him to have double vision all day long, all day. And the provider that he had previously been seeing said, well, that's just a side effect that you're going to have to deal with. I don't know about you guys. I could not live with double vision my entire life, day in and day out. I mean, honestly, you're sleeping, so it's not all day long. I get it, make the jokes. However, the second you wake up, you're dizzy, and then and you have double vision, and then the second, you try to go out the door, you try to work, you try to do anything, you can't focus, that would be miserable. So that's what we're talking about, if it's having a negative impact on your life. And every patient is different. So just because it's important to you and it's not maybe important to your friend or to a family member, they're like, oh, I just deal with that. That's the medication I take, I have to. That's not always the case. And so that's why you need to actually have the conversation with your providers as well about acceptable side effects or acceptable limits to that. And then if it's not, what are the next steps? And then you're also, you can be worried about missing medications. In the years that I've been doing this, I do not like pretending I'm your mother, because I am not. You have mothers, they are wonderful, I am sure. So when we talk about missed medications, it's not necessarily of if you're going to do it. To me, it's when. Where no one's perfect, and none of us, even without seizures. We forget medications all the time. We forget vitamins, we forget things, we forget our coffee cups, we forget this, that. That's just normal life. And so for me, when we're talking about this, if someone is truly inconsistent with their medications, or if you have a patient, you're a caregiver or a family member, that they miss medications, and you know that something that you can't, quote, miss would be a good option, VNS is also a good option for this, simply because you can't miss it. You can't not take this. The device is going to be on, as long as the battery is running, the device is going to be on. And if you guys haven't noticed, everyone in these pictures is actually a patient or a family member of a patient. So VNS therapy benefits, as we talked about, fewer and shorter seizures over time, quality of life improvements. If you're having less seizures, less severe seizures, less frequent seizures, you're going to have improved mood. I would. You're going to have improved memory. You're going to have improved attention. The number one complaints that I have for the majority of our patients is memory and attention issues. And is that the seizures? Is that the medication? Is it a combination of both? VNS, because of the way it works with that neuromodulation and the ability of sending up those electrical impulses, not only is it going to help that because it helps seizure control, but it's going to change actually the way that the electrical activity is moving in the brain, in the sense that it's going to counteract a lot of the side effects that can be from medications or the seizures. It's pretty interesting. You're also going to have fewer healthcare emergencies and costs, decreased seizure intensity, better recovery. There's no medication-related side effects. I'm not saying there are none, but there are no medication-related side effects. And you can also use VNS with any other medications out there, and also treatment options. So this is talking about ketogenic diet. This is talking about corticosteroids if you're in childhood. This is also talking about the other devices and the resections from the previous, when we talked about intracranial interventions. When you talk about quality of life, how do we know this? And this was retrospective. These are from actual patients. VNS therapy has improved overall quality of life for many people with uncontrolled seizures. And these are the percentages of people with therapy who have shown improvement. As you can see at the bottom, there's close to 1,200 patients that replied, and you've seen improvements. And this is all pretty phenomenal to me as a provider. Almost 40% improvement in memory, 40% improvement in achievements. That's in school. So if you have a child, this is where it gets really important, because we know in early childhood and throughout grade school, it's very important that they understand the basics. It's very important that they are able to understand and have attention to do these things. And so if we can help them retain that information and get it in there, it's automatically going to have improvement in achievements. Over almost 50% improvement in verbal skills, 50% improvement in mood changes, for me is huge as a provider for adults. Over 50% decrease in seizure clusters, also huge, decreased postictal period. And as we talked about, increased alertness, simply because A, you're not having as many seizures, and B, from a neuromodulation standpoint, when you're provided that electrical impulse, it actually can kind of counteract some of the negative side effects, not only from seizures, but seizure medications. If you are not familiar for mood, and this is a different talk, but LivaNova VNS had FDA approval, I think it was 3 or 4 years ago now, FDA approval for recurrent and difficult to manage depression, which is huge. As someone who's been doing this for close to 15 years, as we talked about, we knew that VNS helped with mood, period. Just did. I don't have one patient that says this device made my mood worse, and I can stand by that as clear as day. But the interesting part is when we put this in, people had improvements in anxiety and depression, and overall just an improvement in their mood. And when we thought about it, it's the same thing as if you've ever heard electroconvulsive therapy, where they're providing some electrical stimulus to help with this. And so we know when it's providing the electrical stimulus, it's benefiting the serotonin, the neurotransmitters, the neurohormones, i.e. you're having mood changes. In addition to that, it's also environmental, because if you're having less seizures, your anxiety will likely significantly improve. And if you're having less seizures, you're going to have improved depression, simply because you're not having to deal with as many seizures. So there's my PSA. If you're not familiar, there's FDA approval for depression as well. So VNS in children, I'm not in pediatrics. So if you have questions specifically about pediatrics, we can take them and I will answer them if appropriate. If not, we can have someone get back to you. I'm sure I'm going to count on the LivaNova reps and Chuck and some of our friends to help me with that if there are specific questions that I can't answer. But in children, just like adults, this is for uncontrolled seizures. And as we talked about from a developmental standpoint, they are harmful to the pediatric brain. Our pediatric program is very aggressive here, our counterparts. And that's because they know the significance of young brains and the developmental process, and they want to be as aggressive as they can to help shut this down for the best quality of life. As we talked about, it's FDA approved for children as young as 4. It's greater than 35,000 children worldwide. And again, when we talk about development and quality of life improvements, 63% of children have fewer seizures. Close to 50% of children have shorter seizures. Again, close to 50 have less severe seizures, and 40% have better recovery after seizures. And that is taken from children as well as caregivers for the most part, when they're looking at this from a retrospective view of what have you seen with the device. So benefits of VNS therapy in children, and I apologize, I have to use Google Docs. And so if you notice some of the margins are off, but this is all the relevant material. The facts: trying more medications doesn't always improve seizures. Many children with epilepsy have reported mental health issues such as depression and ADHD for various reasons, as we've discussed and kind of got into very preliminarily. And about 1/3 of children with epilepsy will not outgrow seizures. The only thing you can outgrow, quote unquote, in epilepsy, the ones that we have seen, is with your absence epilepsy or absence seizures. And even then, I get a handful that can and many that can't, and they still will require medications. So proven benefits with VNS, why would you do this? Seizure control with VNS therapy continues to improve over time. I think this slide is in here. If it's not, please know that the more that your brain is exposed to the neuromodulation or the electrical conductivity that we're talking about, that VNS provides, the better the seizure control will be. And this is true, we've seen it. I don't tell my patients to look for anything until at least 6 months. I hope they see improvement before that, but the general rule of thumb for me is at least 6 months, because I know that their brain has been exposed to it long enough and that the programming has gotten to a point where I know it can penetrate and get up to the brain and actually do the things that we are expecting it to do. And people do get better over time. If you look at the data in the next couple of slides, says 24 months is when you see kind of the biggest jump and improvement, and then it'll stay that way throughout the duration of the device. Quality of life improvements in mood, memory, and attention, and patients were 3 times more likely to become seizure-free if treated early with VNS. And that's the very interesting part. As someone who's an adult provider, we get patients when they've had seizures for 15, 20 plus years. And I will tell you, if you are refractory at that point, it is very difficult because your brain has been seizing for a very long time and it's gotten very sophisticated. So if we can treat patients more aggressively in the beginning and get better seizure control with quality of life, optimization of medications, all of those things that we've talked about, you have a higher likelihood of actually maintaining seizure freedom and seizure control a whole lot better if we can do that. And that's in children. That's why, as I said, our pediatric program is very aggressive when coming to interventions, including VNS. So how it works, this is what we kind of talked about. And I have to show my bear. I love him. I hope you guys can see him. These are actually, if you have a provider, your reps should be able to get them some of these. We have these in our rooms. And we like these guys because it's helpful when we're talking to you about surgery. And even our adults like holding them. But it's also helpful because in his little pocket, in his chest here, he has a pocket. And this is, I want to show you, is how big the devices are. So when we're talking about what does it look like, it looks big on the bear, but this is one of the bigger ones. This is a 105 and a 106. And then in most pediatrics, you'll get the smaller one. This is the M1000, but we also have this with adults as well. So this is how big we're talking. And if you're, a relatively normal sized human being, you can see them on my thing, these are not that big. So when we're talking about implanting the device, these are your batteries. And the ways that these work is 3 different modes. Standard mode is prevention therapy. This is therapy that you cannot turn off. This is delivered through regular intervals throughout the day. They hope to stop the seizures before it even starts. This is that neuromodulation mode that has become very popular with RNS, DBS, all of these things. LivaNova was the first to work into this therapy and look at it and to see how it works and why. Providing that electrical stimulus actually will help modulate the brain so that hopefully we prevent seizures, period. When you need to detect and respond, if the seizure is more aggressive than the output that we have and it's just more powerful, this is the responsive part that I was talking about. This is the auto stim feature, where this will deliver therapy automatically when it detects an increase in heart rate. This is not heart rate from working out. This is not, depends on if you're like me and stairs are not your friend. If your heart rate jumps over a certain period, an autonomic or an involuntary jump, this is when this device will go off. And it hopefully will stop the seizure once it starts. This can be programmed to be exactly the same as the normal mode. So if it goes off during the day, you won't even feel it, but it's going to provide that stimulus automatically. And this is very helpful if you have seizures in your sleep, if you have very little warning before the seizure starts, if you're unable to use the magnet yourself. This is something that we can program to deliver automatically. And when it detects that heart rate change, it will provide a stimulus. Then the last one is a magnet mode. This is like an inhaler for an asthmatic or insulin for a diabetic. This is you or a friend or a caregiver when you either feel the seizure coming on or you see the seizure coming on. This is someone that can actually swipe the magnet, and it looks very similar to your Apple Watch. So thank you, Apple, for coming out with this. It's pretty much exactly like this. What you're going to do is that you can take it, and usually you can wear it on the inside or it's on a belt clip. And all you're going to do, if you can see me, I apologize, you're just going to swipe it over. And when you do that, it's just one swipe. You don't have to swipe it 100 times, and you cannot overdose your family member. So brothers and sisters, you can't just swipe and swipe and swipe and electrocute them. These are real questions we've had. But when you provide the magnetic stimulation, when you provide the magnet mode, it's typically a higher output. And the reason for that is that's when you need it. That's go time. And so this is your rescue mode. This is like using lorazepam or diastat or anything else. This is what you use in an emergency. So again, it serves two functions as we talked about. It provides an extra dose on demand, can stop the seizure, shorten the seizure, decrease the intensity. And if we do all of those things, it can improve the recovery period following the seizure. You can also, I said you can't really turn this device off. You can in one way, and this is by providing, if you wanted to, if you were singing, public speaking, excuse me, even if you're doing intense exercise, or if you're doing a talk like this, if you wanted to turn it off, all you would do is you would hold the magnet over the device. So when you say that, you're like, why would I hold my hand over my chest the whole time? You don't have to. You can simply tape the magnet over your chest. When you do that, the stimulation and the delivery will stop. However, as soon as you take it off, it will go back into the modes that it has been doing, the normal mode, magnet mode, auto stim, it'll just click right back in all the same settings. That is the only way you can, quote, truly turn this off without coming into the office and us actually programming it to not provide any output. But we do this too if someone's having a little bit more sensitivity. If we've increased the settings, we'll actually, you know, if it's kind of irritating them or they're just not as comfortable, what we do is tell them to hold that over there and, you know, temporarily suspend it for a couple of hours, take it off, and then get used to it again. This is when we talk about latest technology, people always have a million questions of what can we do and what are some of the restrictions. So in the past, VNS, LivaNova had some restrictions with MRI, simply because MRI, if you didn't know, had magnet in its name. And what we just talked about is there's a magnet mode. So obviously there's a magnet inside that generator, that battery. So when you talk about going into an MRI, we just have to make sure everything's safe. And so if you look on the website, it'll actually talk about the exclusionary zones for MRI. However, with the newest devices, there are no restrictions on brain MRI. Okay, so just to let you know that now, with the newest devices, the 106 and the M1000, there is no restriction with MRI of the brain. There is some restrictions still with basically the thorax, the chest area. So if you're looking at spine imaging, that's just something to talk to your provider about. If you're someone that has scoliosis, spina bifida, things like that, it's a consideration of if you'll need imaging, how, and if you need the MRI versus CT, because there's still some exclusionary zones there. But everything else, extremities, has all been fine and is well within that zone. Again, please reference the LivaNova website. It'll talk about all the MRI restrictions and considerations there. The newest features too with the M1000 have customized control, which is very cool. Basically what this means for me as a provider is if you have more seizures at night, what I can do is program your device to go off just at night if you want to. And then during the day, if you're at work or you're doing something, we can actually turn this off. And the same thing goes for the day. If you have a lot go on some of my patients will say, from 5 to 7 at night, I just have a ton of seizures or I have a ton of myoclonic jerks, something's weird. We can actually increase the programming for that period of time. And then after that, it will kick back into the regular programming that we have. We can also do scheduled programming. Again, with the M1000, that newest device, what we can do is if you live 2 or 3 hours away from us, back in the day, what we used to ask you to do is every 2 to 3 weeks, you'd have to drive in. I sit there with my little Palm Pilot. We had those. We thought we were very cool back in the day. And what we would do is make the programming changes directly there. Now what we can do is we can program it up to 7 steps. So if you talk about every 2 to 3 weeks, that's at least a couple of months before you need to come in. And every provider is different with this. I try to maximize that because I like you guys, but I don't need you to waste your gas and come see me all the time. So when we look at this, what we can do is we can program the device to go up on the output when we're setting this up for you. We can do that automatically every 2 to 3 weeks, every 4 weeks, whatever we decide. But basically what that means is I give you a printout saying, here's the date and time that it's going to go up. And that will actually increase your settings, but you don't have to come in and do this. So then at the end of those, month or 2 months, whatever it might be, whatever your comfort level is and your provider, you can come back in, be reevaluated and see if we need to schedule some more programming. When we talk about programming and why would we need to do it, this is when you get the device first implanted and we don't just want to turn it up as high as we can and say, let's see what happens. You guys would really be mad at us and that would be very cruel. It's not that it's going to hurt. When you talk to people who have had this before, and I can't tell you that I know because I've not had this, When you provide the stimulus, a lot of what people feel is a tingling. It's not like you're going to be electric shock every time and you're going to jump. If the people program it that way, you need to talk to us. We have better ways of doing this. What you're going to do is we want you to feel that tingle, but we gradually want it to go away and that you to get used to it. And the way that we do that is we create some scar tissue on the vagus nerve. And so the way that we do that and the way that we prevent you from not wanting the device to go off, I don't want you to be scared of the device going off or anticipating it, is when we program it, we want to go up very slowly. So when we do this, this is what we're talking about here is anytime we make programmatic changes, when we're trying to maximize output, we do it slowly so that you don't feel anything, or if you do, it's just the tingling, not anything else. And so this is where that scheduled programming could benefit you if you can't drive, don't want to drive, or if you live far away from your provider. This is what it looks like. As we talked about, it is not brain surgery. The generator and lead are implanted during a short outpatient procedure. This is through a neurosurgeon or an ENT. It's a small incision in the neck. This is prime real estate though. This makes it look very easy, but you've got a lot of arteries and veins, vocal cords, you got all kinds of things there. And so this is why we send you to an ENT or a neurosurgeon. And then the battery is an incision on the chest area. And this is, for pediatrics, they might put it a little bit closer to the axillary or armpit area. For my adults, what we do is typically put it right on the chest there. Battery life is anywhere between almost 5 to 10 years. There's an asterisk there. Where is it? Yeah, specific to model 1000. But I would also say here, there's a little caveat in that my patients tend to go anywhere between 3 years to the max I usually do is about 7. I had one guy with 10, but other than that, we usually recommend that they get a battery refresh at about 7 years. The reason being, when you talk about batteries and battery life, it's just like when you have your phone, and mine is just purple, by the way, because I love purple and epilepsy was what I was meant to do. When we talk about batteries, just like your cell phones, even though you've had that phone for 4 or 5 years and it still looks okay, when you charge it, it may not go to full 100% or your 100% didn't look like it was before. And that's what we worry about when we have this device. Case in point, I had a patient, we'll just call her Melissa. She went for a re-implant today, her first battery change. And her battery looked okay. And 4 months later, we had it looked at again, we checked it, and all of a sudden it's end of service. In that 4 month period, her mother was reporting an increase in seizures, increase in myoclonic jerks, and she was feeling some irritation right there. So all that tells us is even though the device is saying, yes, it's fine, obviously it wasn't doing the work it was doing, say, 3 or 4 or 5 years ago when it was first implanted. So sometimes when you get a refresh like this, if you've known anybody, they'll tell you it's a little bit more intense when they have it implanted again. And that's simply because even though the device was, quote, working, it's just not delivering the same impulse. So I would say 10 years is really the max. Most of my patients go every 7 years maximum, simply because technology has changed. We have different features that we might need, just like the auto stimulation, and the battery is not going to be, the integrity of the battery may not be as good as it could be with the newer devices. So side effects, it's not without side effects. As I'm not going to tell you that everything is easy peasy, and I've never had anybody that had any issues. However, the majority of the side effects you see here, hoarseness, shortness of breath, sore throat, and coughing, these occur right after implant. And that's because, again, we're in prime real estate right here. You got to swallow, you got to eat, you got to talk. And so when you do this, there's going to be some inflammation in that area just because you made a cut. I don't know if you've ever had surgery before, but even if the surgeon does it and if they're the best in their field, your body's going to react as if it was a foreign, invader, because it was. And so all the neutrophils, fluid, everything goes to that site and it gets really irritated and it can swell. That's a lot of when you see the hoarseness, shortness of breath, sore throat, and coughing. Shortness of breath for me is I've actually, knock on wood, I've never seen it. The biggest ones for me are the hoarseness and the coughing with the stimulation. These side effects do get better over time. If it's not, that's when you would want to talk with your provider about how they're doing the programming. If that's a problem for you, I would want to make sure you talk to them and see if there's a way to make that change. Infection is the most common side effect for procedure. However, I would say, again, in the 15 years I've been doing this, I've had maybe 2. And they were pickers. And these are the people that your scar itches, you mess with it and infection gets in that way. I've only had 2. And again, those were people that kind of self-inflicted and they didn't get it done again simply because we found other ways to help with their seizures. And we were worried about continued risk for infection there. So again, we did it right at about 30 minutes, maybe a little bit over. I hope I didn't talk too quickly, but I really want to save enough time for you guys to have Q&A. We can go back on any of the things in the slides if you want. But just for you to know, if you have more questions, or you want more information, we have case managers, clinical education specialists that can offer one-on-one support and have extensive experience in all aspects of VNS. They can also, as it says right here, find a doctor. They can help you find a provider, nurse practitioner or physician, somebody in your area that does this. If you have any questions, and if you're in the Texas area, happy to see you as well. Even if you have another provider, we don't steal patients from doctors. However, I'm more than happy to meet with you to have these conversations if you and your provider think that that's an appropriate thing to do. Again, they will also help with insurance verification, which is wonderful. They actually help us with authorizations, which if you've ever dealt with insurance companies, it's the bane of my existence. If you work in insurance, we love you, you're necessary, but it is very difficult to manage. And they can also help connect, just like with Purple Day and the Anita Kaufman Foundation that we're doing tonight. They can also, they have ways to connect you with other people who use VNS and caregivers and family members. They have all kinds of platforms that you can hear more about the device itself. And I'm going to turn it back over to Chuck, and I will stop sharing my screen. And if you guys have questions, feel free to type them in now.
Thank you, Liz. That was a fantastic job. You covered a lot of ground in a short period of time.
Thank you. I hope that it was
Covered a lot of
intelligible.
questions too, so I don't have to answer too many, but we have a few. We have a few there.
Perfect.
You answered the one about insurance there, and they were asking the cost of it, and is there a follow-up cost, which would really kind of be just a battery replacement, like you said.
Yes, sir. Yes.
Or visiting their doctor to have it adjusted and titrated.
Right. So it is not free. This is surgery. So unfortunately, if you are underinsured or uninsured at this point, that would be difficult. They don't do as many of the charity cases as they did before. We try really hard, but it's very hard to get people to do it now. So Medicaid, Medicare, even commercial insurances, the Obamacares, we take all of those things and we have been able to get this approved. They will work with us. So if we have an insurance that's a little finicky, I won't name names. If we have someone who's finicky, they will actually help us get those authorizations so that it is more of a smooth process. The initial is high, unfortunately. The device itself, I think, is anywhere between 15 and 20,000. But again, this is a device that lasts up to 10 years. The hospital or surgical centers, those all vary. And that's where I would work with the provider to see what the best options are if they have different privileges in different places. But as you said, Chuck, the initial cost is high. But if you go to any of the other VNS talks, within, I think it's, Lauren would be mad at me for not remembering off the top of my head. I think it's within 12 months that you actually recoup that initial cost. In the savings benefits that we talked about by decreased hospital visits, decreased ER visits, decreased time in office. Hopefully, if you're using a lot of medications, if we can adjust those, all of those things can go down. Hopefully that helped.
I was fortunate to have a meeting with one of your data analysts last week, Sanjay, and I learned so much information too, because I've been aware of this device for 20 years now. And you brought it up a minute ago in the presentation. The longer you have the device, the better the success rate is now, up to 8 to 10 years.
Isn't that crazy?
I remember at the beginning, people would say, oh, they want that immediate, you know, and then they say at the end of the year, you know, I want to take it out.
Right.
Now we know, well, wait with it. Let's moderate, get adjusted. And then the third year, the success rate. In the fifth year, I was going, wow. And then down to 8 years, it's absolutely amazing. And the other thing you did bring up while we're gathering the questions here, LivaNova is so wonderful to have your case managers that will work with somebody. So we want to make sure we tell everybody how they can get a hold of them, because they will help you through the process. And as Liz said, the advocates can even get you with people who have the device. So this is wonderful. Had another question here from Sarah. She said her daughter got the VNS last October. She knows she can see on a program how many times the device is activated. Should a doctor be able to see specific dates and times that the device activates for detection and response mode?
Yes, for auto stimulation, yes. So Sarah, I'd like to tell you that we have all kinds of wonderful, sophisticated data gathering in the device. This is phase 1 of the data gathering. So we do have the ability to look at that. Your provider would have to run a detailed data pull, and we can actually look at days and see how many times that day it was pulled and the month and all of those things. So the short answer is yes. The bigger answer and the question would be how long of the time frame from when she's had these seizures to when you're seeing the provider, because there's only so much data that can be pulled. So unfortunately, if she's having a lot of stimulations and it's been 6 months, they may not be able to pull that data because there's only so much that the device will keep in, and then it cycles out just like other things, because they're just like your iPhone, there's only so much space. So the short answer is yes, Sarah. And if you want to see those, oh my gosh, did I mess up the screen? Sorry, I pushed a button. Okay. The short answer is yes. But what I would also caution you, Sarah, is not every auto stimulation is a seizure. And I know you're like, well, wait a minute, that's the whole point. It is. But for everyone else too, if you're not familiar, when we talked about the heart rate changes for the auto stimulation, there's different sensitivities that we can set it to. So if you're at a highly sensitive one, because again, we don't want to miss big seizures. So when that heart rate jumps 20%, we're providing the stimulus no matter what. So if your daughter is active, or if she's jumpy like me, and my husband's very quiet, so I'm just trying to make sure he's not behind me. And I jump very quickly. My heart rate will actually jump up. So if she is like that and it's highly sensitive and it's picking all those up, yes, you will see a lot of stimulations, but I don't want you to worry that your daughter's having, say, 100 seizures a day that anybody's missing. That's where you'll have to work with your provider on your seizure log, presentation, and then where the auto stims are occurring to see if there's correlation around that time or if you need to make adjustments in the programming.
I she brought up the information of the heart rate.
Yes, sir.
The newer device monitoring and that, and to be able to adjust to that and respond to it, because some of the later research on SUDEP is looking at a relationship to the cardio system, you know, in SUDEP. So having a device now that can monitor the heart rate, you know, is wonderful as well. Another question here that Tina asked, and I was going to ask it too. Are there any limitations once you have the device, you know, to participate in sports? You know, whether it be swimming or soccer or.
Again, short answer, no. Tina, we'd have to go into what you're talking about. If you're talking about like strongman, Ironman, you're going to be pulling a Mack truck behind you. We'd maybe need to talk, Tina, because it's probably not the best for you with your chest being pulled back that much. But regular sports, absolutely 100%. I would work with your provider and the surgeon, ask those questions ahead of time if it's something very specific. Volleyball is fine. Basketball is fine. Wrestling, you'd have to ask just because of the moves and the way that it would work. We'd want to make sure we put the device somewhere where it's possibly not going to get knocked out. The biggest risk when you're talking about physical activity or is this okay, is that you don't want to knock the device out of the pocket. And so again, in your chest area, I didn't go into it too much, but if you want the nitty gritty, it's sitting in the pocket of fat. We all have fat, some more than others. However, there's a pocket of fat in anywhere and in the skin tissue. So when we talk about it's implanted on the left side, it's because 85% of that goes up to the brain. On, if you've ever studied afferent, efferent pathways, it's totally nerdy. We can get into it. But when you talk about it left side here, we're not in the heart, we're not in the lungs, we're not anywhere in there. Okay. We're in the fatty tissue. So when the surgeon goes in, they create this little pocket essentially in the fatty tissue where the device sits. And so the biggest risk, Tina, when you're talking about exercise is it going to pull that chest so much that it can pop the device out of there? You're not going to break it. You're not going to, hurt yourself. It's just going to, if you pop, it's going to hurt if you pull it out of the pocket. So we would just have to, the biggest restrictions I think are more if you're looking at weightlifting. I had a guy who did incline massive weightlifting. He should not have been doing it, but he popped his out because he was doing way too much and too much weight and it just pulled, but we were able to successfully reimplant it. So short answer is yes, but talk with the surgeon and your provider if you have specific questions about very specific sports activities.
Thank you. I want to remind everybody, because some people came in after we started, if you do have a question, just open up the chat, type it right in there, and I'd be glad to ask it of Liz. I have kind of a personal question. I grew up, my mother had rheumatic fever when she was a teenager, so she had heart problems. Can you have a pacemaker at the same time you can have a VNS?
Very good question. Yes. And you can even have a defibrillator with it as well. So you'd want to get clearance from your cardiologist. And obviously the placement is a consideration. So we'd have to, wherever that is and what it looks like, you'd want to make sure that we're safely away from that. The only thing that's a consideration for someone who has a defibrillator or a pacemaker is we will not be using the auto stimulation feature in those patients. Obviously, if your heart rate's paced, we're not going to get it to rise above that if it's working. Please God. If it's working, it's not going to rise, so it's not going to really be helpful with the auto stim. But yes, we can do that. I have patients who have cardiac issues and we have implanted them successfully and there's no cross interaction. We would just need to get clearance from the cardiologist on the specific medical issue.
Wonderful. Sarah had a question here. After you have the device placed, how long is it kind of generally before they might start titrating you off your medications? And, you know, I've known some patients got completely off meds, and I've known some that have stayed on for a while.
Right, right. What's the general? Sarah, you're putting me in hot water here. Because Sarah, I can't have you go back and tell your doctor, be like, this girl said, and reference it and show the clip. But good question. So I would say I wait with any surgical intervention, and we're even talking about resection, intracranial devices, all of that. My group, we're very conservative. And again, we work with adults, very refractory population. Sarah, you made me laugh, just general. I'm just kidding, I know. But I always preface that, like, don't take my video in there and come at your provider. It would make me laugh though. When we do this, even if we're doing something as aggressive as that, we wait a year to 2 years before we touch anything. And that's not because we don't think we've done a good job. But what we want to know is give you enough time to heal. But then what we don't want is that brain to create new pathways for seizures. So we need to make sure that we're doing our job successfully enough, because as I talked, seizures are very smart. And even if you've had a resection before, you're here because you're having seizures again, and you're seizing from what we call the contralateral or the opposite side. That's when you look at it and you go, oh my God, why am I doing this? And it's because the brain's very smart. So yes, Sarah, 4 meds. I would say I would look at least 6 months. I would say probably 12 months. But could we potentially bring off some of those as far as decreased doses? 100%. So Chuck, I never promised getting off of medications. I have a handful that are. But Sarah, if I can make your daughter's quality of life better because she's maybe on, and do not hate Depakote, I love Depakote, but maybe she's on a high dose of Depakote and she's not doing as well in school because she can't pay attention because she's so tired. If I can pull that down conservatively and give her a better quality of life just with that and still maintain good seizure control, I would do that as quickly as I can. And so for me, the earliest I do that is right around 6 months, unless we've seen such a significant improvement before that. Pediatrics, I don't know, because PEDS does it a little bit differently, but I would definitely ask your provider when that would be a possibility so that we can hopefully get her off. 4 is a lot for a daughter. If she is adult, young, it doesn't matter. 4 medications is a significant amount. Good question, Sarah.
I've seen that in my 28 years and seen people reduce the medication, or if they're on 3 or 4, might get down to just 1.
Right.
And the quality of life improves, the side effects, everything else we can get rid of there too.
That's always our goal. Oh, Sarah, yes, ma'am. 17 at 75 pounds. You're breaking my heart, Miss Sarah. I want you to come to our pediatric program. We'll see what we can do. But yes, very real question. And yes, I would, as Chuck was saying, I would try to simplify the regimen. That's what we do pretty much all day long, is if I can get you on the least amount of medications at the least effective dose, like not least effective, most effective dose at the least amount, that is my goal.
Well, I was sitting here too, and you spoke earlier, and like I said, I'm an old timer now. I remember in the days when the neurologist or the epileptologist would say, if you tried 4 to 5 medications, we need to look at options. Then a few years ago, it went down to like 3 medications. And we do a lot of these Zooms with epileptologists, and they're saying 2. If you tried 2 classes now, we need to look at alternatives like this. And I liked your comment earlier when you said the sooner the better, we get a better outcome.
Yep.
So I've had people come to me, and I have to share a personal story here while we're looking at more questions. I have a dear friend of mine just started dating a young lady, and he gets a hold of me a few weeks ago, and he says, she has epilepsy. I was, oh, yeah, cool. I look forward to meeting
I know what that is, yeah.
Yeah, so talking to her the other day, we told her that I've been involved with this for many years. So I was talking to him and her the other day, and she had resection surgery about 8 years ago. And they didn't get all of it. So they wanted to go back and do it again. And she said, no, I'm going to get a second opinion, look at other options, because they never even talked to her about neurostimulation or VNS prior to it. Yeah. So, you know, she was having more seizures, but she said, I don't want to know if I go through another deep brain surgery. So she had the VNS, and she, after that,
it's been great.
about 11 months, she's fine. She loves it. And she was talking about the little magnet, you know. Yep.
It looks
So
like an Apple Watch,
fantastic.
really. Like it was uncool before Apple Watch came along, and now it's okay.
Well, matter
And
of
you,
fact, I'm looking over here to Liz. She's kind of posted a question there too. She says her daughter already had surgery, still having partial seizures with clusters. Is a VNS worth considering? Lisa,
yes,
I didn't see your question. Apologize. I would have answered that first, but we're going to ask it of Liz anyhow.
yes. Lisa, yes. The short answer is yes for that. I would say any option is on the table at this point, no matter what. It's not a dumb question. It's not off base. Even what you say, the callosotomy, and for those of you that aren't familiar, corpus callosotomy is you have two hemispheres, right and left. Right down the middle is, think of your major highway. In Texas, it's I-35. And so when you have the corpus callosum that's here, that actually allows the left side of the left hemisphere to talk to the right and vice versa. So when you have someone like Lisa's daughter, who likely was having very aggressive either convulsions or drop seizures, where if you're not familiar, you'll be walking and you simply will fall out. High risk for injury, high risk for head injuries. You do callosotomies typically on younger patients. We have done it on older, but it's usually done in childhood, and it's done to basically disconnect the left and right hemispheres. So if you're having generalized convulsions, break that up, not allow it to propagate across to the other side, and also to really help with drop seizures, so it'll decrease the risk for injury long-term. So yes, Lisa, if she had a corpus callosotomy in 2010, her drops are gone. And hopefully her generalized seizures are gone if she ever had any. With partial seizures or focal seizures, as we talked about, this is what the device was made for. It was also, I love it for seizure clusters, because you're getting that neuromodulation that Chuck talked about, but you're also able to use something like the magnet or the auto stim on a sensitive programming, that once that starts picking those up or you start seeing it, you can shut it down. She can shut it down if she has the ability to do that. So I think definitely it is worth that conversation. And there's no contraindication for that with a VNS. And if someone does, if your provider says, well, I'd like you to look at brain surgery again, or focal resection, or whatever it is, you can have that conversation. If you don't want to do brain surgery, definitely consider this. The risks, I think, are very low when you look at the surgical intervention. Again, there's never going to be like no complications in surgery, period. However, the risks are, I think, so much lower compared to the benefits. And at this point too, if she's already gone through the callosotomy, that alone is more aggressive than anything that VNS is going to be from a surgical standpoint.
You said the surgery is kind of an outpatient surgery, but how long is it kind of the recovery and after the implant?
Oh, from the actual surgical time when you're going to be there, it's like hurry up and wait. So it's so annoying. And I have gone through outpatient procedures, so I get it. There's going to be a lot of prep time. You're in the OR for probably an hour total, just depending on your situation, anesthesia, all of that. And then you'll go to recovery, because you will need general anesthesia. You'll need to go recovery, but then you should be out of the hospital within 6 to 8 hours, period. The recovery after that, once we do the initial implant, I would say we typically wait to do sutures coming out, and anything that is, a lot of times it's just glue here for sure. There might be some sutures here. Those usually come out within 10 days. And I would say that's when all of that, as far as swallowing, healing, all of that stuff, that should be, it should be better at that point.
Thank you for answering that. Amy has a question here. Does VNS therapy help children with Lennox-Gastaut syndrome? She has a 12-year-old and on high doses of 4 different meds, which we know,
Yeah.
and they've already tried 2 others that have failed. So
Yeah.
need to look at options.
Yep. Short answer again for this is yes. So with Lennox-Gastaut, if you're not familiar, everybody, it's a pediatric syndrome, and there's very specific EEG changes that are more of, it's multifocal, primary generalized, it's kind of everything. So I would say yes. You have to make sure that when your provider's sending the referral, they use the right CPT codes. That's not your problem, that's theirs. Have I seen benefit in patients with Lennox-Gastaut and VNS? Yes. I'm not going to promise you that it's 100% effective. If you're not familiar with Lennox-Gastaut, everyone, it's very aggressive epilepsy. So I would never promise you that this is the golden ticket, this is what's going to work. But it is definitely worth a consideration of putting it in, even if it's to decrease the bigger seizures, improve quality of life despite being on that medication. I always say, again, just like with Lisa's daughter, it is worth the conversation of what do we think from an efficacy standpoint this could provide us versus another medication. And again, if you're Lennox-Gastaut with bigger seizures, sorry, Chuck,
No.
if this can decrease the risk for SUDEP or death from a seizure, Again, to me, that greater than 50%, I think it's even like 65, greater than 50% seizure reduction, or excuse me, decreased risk of SUDEP or dying from a seizure. To me, it's hands down done. As a parent, as a patient, as anything, I know it's scary to go undergo surgery, but from a peace of mind standpoint, I'm done. And I actually had a patient, she went last week. She actually, she's getting older, and her mom was concerned when they pass away, what's going to happen, because she has Lennox-Gastaut and she lives with them, but at some point she will have to go into a group home or some type of facility, and they're anticipating this. And she had an older model. She had a 102 or 102. It was 102R. So older model double pin device. She actually underwent a lead revision, which we put a new lead on and take the old one off or clip it, just to get the M1000, which has the auto stimulation feature, because her mother wanted to decrease the risk of her ever having the possibility of dying, or, you know, any chance of this when mom and dad aren't around to provide care for her.
Wonderful point. Wonderful point. And for some of you, you might not have heard the term SUDEP. A lot of neurologists are scared to discuss it with anybody or even bring it up. They don't know how to, but it really stands for just sudden unexplained death due to epilepsy. And we really don't know. I mean, there's a lot of research on it. And when I mentioned earlier, a lot can be related to heart. So heart monitoring, the cardio is so important too. And you touched on another point when you're talking about the medications, and as an advocate for nearly 30 years, I've talked to hundreds of people about VNS. They call me about it and they want to know, oh, you know, it's surgery. Well, we talked about it being an outpatient, but I'm asked them that question as you brought up, how many medications? And I said, I've learned from being in it so long from the neurology community and the epileptologist that after you've tried that second and third medication, the chance of the third or the fourth working, you're down to about 15% chance.
Yeah.
So if neurostimulation VNS even has a 50-50 shot, is it worth it
something?
To you? Is it worth it to you?
Agree.
And then you bring up the consideration of SUDEP.
Right.
But you know, when it doesn't work, a question is asked too, can it be removed?
Yes. Easy. With the lead revision. So when you have the lead around the vagus nerve, again, it's prime real estate. We may not remove that. It depends on your surgeon. If anything, you can have it clipped right there, and that actually takes away all the MRI stuff that we had talked about. You can get an MRI anywhere if it's clipped very short to where it was implanted. The battery can always be removed. Yeah, I see Jean was saying my epileptologist doesn't want me to get it because she's afraid if I don't react to it, that it can't be removed. Jean, I don't know who your epileptologist is, but I would have them talk with a LivaNova representative or a surgeon, because it most definitely can come out, and it should help with your gelastic or temporal lobe epilepsy. It's something that we use all the time on temporal lobe epilepsy.
A good question here that was just brought up too. Ladies had a couple surgeries, you know, and still not controlled. And she'd like to look at VNS, but her doctor thinks it might not work.
Yeah.
You know, I can kind of go off here as an advocate. And I say this because I recently had some surgery and had some complications. It's always good to maybe sometimes seek second opinions. I know it's hard for you to say, Liz.
Yeah.
But as an advocate and a layperson, I always tell people the ultimate goal is to search for seizure freedom.
Yep.
And it can be attained. And I'm not saying that as a layperson, I'm just saying from experience and what I hear from the neurology community.
Yeah.
So if you're not getting the answers, you might want to check a second opinion once in a while.
And it can't hurt. And if anyone's, I have had patients that do that. And if I was offended by that, then, you know, I need to find a new gig. As long as you're nice about it, you know, if there's a reason, you know, I would 100% support that, even in our own practice. And we do. So.
Well, there are options today.
Yeah.
You know, when I started out, you could probably count the medications on one hand, and you didn't have other options.
Yeah.
And a doctor, and still a lot of people around the country, might just see their family practitioner or not seeing a neurologist,
right.
not seeing an epileptologist,
right.
who is a specialist that's done extra training in epilepsy.
Right.
And they're not aware of the success
right.
rates of devices like this and other
right.
devices and other therapies as well.
Right. Right.
So definitely. Well, Liz, you did a fantastic job.
Is there anything else? Oh,
we've answered most of the questions, haven't we?
Lisa, yes, available in Canada. Don't ask me where.
Well, you know, I was just going to say that the other day we did one of these for the Epilepsy Association, had the questions available in Australia. LivaNova is an international company. So
yes. I was like,
out.
I think so. Yes. Don't quote me where. And who,
Yeah,
and the last
I don't
one,
know every country.
I don't know
but
everything. I wish I did.
yeah,
Jean.
but we checked that one. It is in Australia. I know it is in Canada.
Yes. And
Yep.
Jean here, don't ever apologize for any of this, please. Um, I love that you have a story. I really wish I could talk to you by yourself because I feel like you have a lot of questions. I would say, as Chuck mentioned too, even if your epilepsy specialist is afraid it isn't going to work, I wake up every day thinking, I don't know if this is going to work or not. None of us have a crystal ball for this. We have our training, we have our background, and some have really great training. I'm not a doctor, and I would never claim to be. We have our training, but then we also have our experience and what we know. And I would never tell you to just not, as Chuck said, ask questions, always ask your provider why and whatnot. I would never tell you something is 100% going to be effective or not, but I would caution you to be too worried about it simply because you don't know if it's going to work. You've tried at least probably 5 or 6 medications that maybe did or did not help. If you do have other chronic conditions, that's something to talk about the surgeon with. But as long as it is safe for you to do that, I think it's definitely something to consider. And again, thank you. And Chuck, I know we're getting near our time, but thank you for this. Really, thank you for the opportunity.
This. Please mention the website again for everybody.
Yes, sir.
Where they can go. I don't know
yes.
if you have time while I do the closing, maybe type it in the chat room as well.
There you go.
Yeah, tell people where they can go to seek out one of your wonderful case managers that work with them and help answer questions.
Yes.
I've had to work with them over the years for patients of ours, and they're fantastic people. Fantastic.
They really are. They have huge hearts, and if they can't figure it out, they're going to find someone that can. If you want to visit vnstherapy.com or call the 1-800 number listed here. It is also referenced in the Epilepsy Foundation and the epilepsy.org, I think, website. But again, even if you just type in VNS Therapy in your Google search, it will get you to their website. On that website, you'll find out more about VNS Therapy connections, how to do that. If you like me at all, I do a lot of the other talks from the community side as well. So you can come hang out with me on a Tuesday or Thursday and hear more about it as well. But here is the website listed for you. I will take a screenshot for yourself and then I will stop sharing so Chuck can do the closing.
Great. Thank you so much, Liz, for the information. And I was going to say the same thing. Follow Purple Day every day, the Anita Kaufman Foundation. Follow the Epilepsy Association. We also have a site that's reaching about 4 million people worldwide now every month called epilepsy.com. Also on Facebook, and we do all these trainings all the time as well. Both of us do. So keep following us. If you have questions, get a hold of either one of our organizations and we'll get answers from wonderful people like Liz. So I want to thank everybody for joining us. I want to thank LivaNova for bringing this message to us tonight. Remind you, we're not done with Purple Day. Let me start over. Purple Day Epilepsy Education Awareness Week, whatever we call it this year. But tomorrow at lunchtime, 12:30 p.m. Eastern Time, US, we're going to have Dr. Allentown talk about TBI, traumatic brain injury in relation to epilepsy. Tomorrow evening at the same time, 7:30 p.m. Eastern US time, we're going to talk about seizure clusters and rescue med options with a PhD pharmacist, Raj Sandhar. So please join us then. We're going to have presentations on Friday and we'll be closing it in our purple on Saturday. So join us. Thank you, everybody. Have a wonderful evening and seek seizure freedom. Do your best, everybody. Good night.
Thank you.